So the number one reason why new graduate nurses absolutely fail when it comes to clinical style questions during their interview is not because you don't know what you're talking about or you don't have the knowledge, it's because it's nerves. You're super nervous. It's an interview, high stakes, and you freeze. They ask you, hey, what do you do if a patient has chest pain? And you absolutely freeze, you don't know what to say, and your mind goes blank. So how do you fix this? You have to prepare. And in this video, I'm going to talk about a couple different questions that you may get asked and how to sound super confident when you are answering these questions, these clinical style questions. And if you need to brush up on some of these concepts that maybe you haven't seen for a while, or you took your NCLEX and you're like, you know what? I'm not really sure how to answer this question. What are they expecting from me? And, sometimes you try to sound too perfect or sound like a textbook, and it just complicates the whole thing. So let me simplify it. Let's get into it. You are in the right place because at the end of this video, you're going to feel so confident with any type of scenario question, case study, any clinical question they throw at you, you're going to be able to answer. All right. So number one, the most important thing is find out what type of interview you're going to. Who's going to be at the interview, because that's important. So let's say you're going to the hospital and it's an acute care position, maybe med-surg, telemetry, or a more higher acuity place like the ICU, the emergency department, or labor and delivery. You are going to have to really know your stuff because they're going to almost grill you a little bit more if it's for a critical care position. All right. And again, it varies where you go, but you really got to know your stuff. They want to know, will you have the ability to critically think, to reason, and to make quick decisions when it's an emergency situation? So watch till the end so that you can get the whole scoop. All right. So find out, again, like I said, where you're interviewing and who is going to be there. Let's say an educator is going to be there, a nurse manager, the team. Is it going to be a panel interview? Because that's very important. Let's say an educator is going to be present, then they're going to want to test your knowledge a little bit because they're the educator. Especially if it's a nurse residency program, they want to make sure that you're going to be successful in that program. So they want to test your knowledge a little bit and, check you out. But you got to remember, it's not like they're going to give you a trick question. They want you to be successful. But you got to know your basics and you got to know your ish. This is literally life or death. So let's get into it. How do you assess any patient? Number one, coming from me, a former emergency nurse, that is the first thing we learn, an assessment, right? Before the patient gets to you, you're already doing a visual assessment of the patient of how they're coming to you. Are they walking? Are they in a wheelchair? Are they in a stretcher? Are they sitting up? Are they talking? Are they awake? What's their color look like? That is the general appearance of the person. So that is your first assessment before you even talk to them or even put your hands on them and lay hands and do an assessment. You visually have to do a general assessment. From that quick assessment, you need to figure out, is this person stable or unstable? And let me tell you, you don't even have to be a nurse to realize that. If somebody is super unstable, you know that this person's deteriorating. It's an emergency situation and you need to move quickly. So number one, if they're stable, you're going to do a full head-to-toe assessment. We already know the nursing process and we know what a full head-to-toe is. If they're unstable, then you have to do a quick assessment and a focused assessment, right? What are the areas that are really crucial? For example, shortness of breath. If somebody is actively short of breath, maybe they have a history of asthma, you're not going to ask them a whole series of questions. You're going to make sure that you take them back. Let's say if you are in the ER, get them to a physician to start ordering meds like a nebulizer, maybe get respiratory involved. And then one important question you might ask them right away is, hey, are you allergic to anything? Or, have you ever been intubated before? That is an important question to ask for someone who has asthma, because you're thinking if they have a history of intubation, then this is a more serious case, because history can sometimes repeat and you're going to move even more quickly, especially if it's a pediatric patient, because pediatric patients tend to deteriorate very quickly. All right. So number one, stable versus unstable. If it's stable, do a full assessment. Unstable, you're moving quick and you're doing a quick, focused assessment and obviously escalating their care to the physician right away. Now, if they are deteriorating, depending where you are, if you're on a floor, an acute care floor, like med-surg, you will call a rapid response. If the person is unresponsive and you check a pulse and it's hard to tell if they have a pulse or not, you're calling a code and jumping on that chest and doing CPR. It goes right back to basic life support, BLS. And then if you're more in an advanced area like ACLS, you also obviously are going to, get the crash cart, call a code, get all that stuff going. And make sure that in some of your answers, you're going to say, I'm going to call for help. I'll stay with the patient and get somebody to get me the crash cart or intubation cart, things like that. But what it all boils down to is you're going to say that you're going to use the nursing process. We all know what that is. Any condition, any patient, anywhere you are, you're going to use the nursing process. And then you're going to just assess the patient. What are other ways you assess the patient? For anyone who's not feeling well, we do the same thing. Part of that assessment is doing vital signs, probably getting labs, particularly if you're in the hospital, doing some type of diagnostics like CAT scan or X-ray or EKG, something like that. And then you're going to notify the physician and notify the team. And then you're going to monitor the patient, monitor their symptoms, reassess them, give them an intervention, reassess, and it's just continuous monitoring until they get better. Or if they're not getting better, you're going to take them to a higher level of care like the ICU. Or if you're in an outpatient setting, let's say you're in a clinic or something, then you're going to send them to the emergency department by calling 911. That's it. Now, let's get into very high level, a couple things they may ask. So chest pain. What are some basic things you need to know about chest pain? You need to think worst case scenario in all of these situations. If someone has chest pain, what are we ruling out? We're ruling out, is this person having an active ST elevation MI, which is the tombstones on the EKG, or are they having an STEMI? Either way, they're going to have positive troponins, which, depending where you work, sometimes you can get that troponin back quickly with a quick blood test. However, sometimes you have to send it to the lab. But the thing you need to do is get them on a monitor, notify the physician, and of course, get yourself an EKG right away for anyone that has chest pain. And the standard is to get it in 10 minutes or less. So if they have a STEMI elevation, like ST elevation MI, you're going to send them to the cath lab because they need to get a stent. And there'll be a slew of other medications that they get. Most hospitals have something called a chest pain protocol. So you can easily say that I will follow the chest pain protocol of this hospital and follow the policies and procedure. And if they're having an STEMI, which is it's not the tombstones, but they do have positive tropes, what we're going to do is we're also going to trend the troponins, meaning you're going to get serial troponins, which means every couple hours you'll have an order to repeat it to see if it's going up or if it's going down. And then obviously treat their symptoms, right? It's a lot of symptomatic care. If they're short of breath, if they're having a lot of pain, you're going to treat all of that. And of course, they're going to be at rest because they can't really be walking around or doing anything. That's chest pain. All right. Next, shortness of breath. What do you need to know? Most of these places want you to know, can you recognize somebody who's in respiratory distress, and what are you going to do about it? Simply, right? Common things, asthma, COPD, CHF, you need to know those common conditions, signs and symptoms, how to treat it, which is the interventions, right? The treatments, common treatments. And then you're going to know what labs to grab and also diagnostic. If someone's having shortness of breath, you're going to anticipate doing an X-ray or a CT. and ruling out other things like maybe ruling out a pulmonary embolism, like a PE, right? These are the type of things that they're going to want to ask in some case studies, right? And you got to know the signs and symptoms. For example, like a PE, if they have sudden chest pain, it just came on, or maybe with deep inspiration, they have more pain. And what's the history? Maybe they just recently had some type of surgery and they're post-op. So of course they would be likely to potentially have a PE. So there are things that you can do like a D-dimer, or, ultimately they're going to get a CT chest to rule out a pulmonary embolism. All right. And of course, asthma, you need to know the treatments, right? They're going to be wheezing. You need to get nebulizers, some steroids, potentially put an IV to get them IV steroids, depending on how bad it is. And then, of course, other treatments are going to be perhaps giving them oxygen, and then know the different levels of oxygen. And then the patient might have to end up on something called BiPAP. So you need to look that up. And what is the difference between BiPAP and being intubated? Obviously, sometimes people have CHF or sometimes COPD. They might be put on BiPAP. But then there's certain criteria that they have to meet. Like they have to be alert. They can't be vomiting because there's risk of aspiration and things like that. And then, of course, they're going to be checking their ABGs, the arterial blood gases, to make sure, are they improving? Because most people that have COPD typically are going to be in respiratory acidosis. So you need to know your acid-base balance stuff. And then definitive, right? If like they're extremely short of breath, respiratory distress, it's not working out, they're not looking good, then you're going to anticipate that this patient gets intubated and then eventually obviously go to the ICU. Then we get stroke-like symptoms or a stroke. You got to know there's two types of stroke: hemorrhagic and ischemic stroke. Ischemic strokes are more common. However, you do have also hemorrhagic. The treatment is very different. So you need to know the treatment for both. Common treatments, if they have any type of stroke-like symptoms, what you're going to do is you're going to notify the physician right away, call a stroke code. That will be up to the physician to decide that. Most places have a stroke team that will come. But before all these people come, you definitely have to do a blood glucose because hypoglycemia mimics stroke-like symptoms. So one of the first things to do is to do a blood glucose, make sure that this patient is safe in a stretcher, put them on a monitor, and move quickly, because once they call a stroke code, the first order of business is to get this patient to CAT scan to figure out, are they really having a stroke and what type of stroke they're having? And if it is an ischemic stroke, they need to get TPA. And they have to meet a specific criteria to get this big clot buster drug, because obviously it can cause bleeding. So, they have to check, have they had recent surgery? Are they over a certain age, like typically over 90? Do they have super high blood pressure? Like it depends. There's a lot of different criteria. If it's a bleed, right, a hemorrhagic stroke, you're going to want the head of the bed up. You're going to want to monitor their blood pressure because we don't want their pressure to be too high because it can cause more bleeding. So neurosurgery typically is involved. They'll tell you how to titrate certain medications to keep their systolic pressure within control or whatever it is, right? And then you're going to do frequent neurovitals, right? Neurovascular checks. You might do Q1, Q2, depending on the severity of this patient. Often they might need a repeat CAT scan. All right. So I hope all this stuff is super helpful. I'm going to be going in more strategies and frameworks on how to get hired faster, how to be more confident in your interviews. So I invite you to join my free webinar. The link is below. It's the New Nurse to Dream Role webinar. It happens every Thursday at 1 p.m. So definitely check that out. You don't want to miss it because once it fills up and you'll have to wait for the next one. Then I'm quickly going to go into a couple other ones. Sepsis obviously is a major infection. Anybody can get sepsis, anywhere from babies all the way up to geriatrics. Anything can cause sepsis. It's a medical emergency when it does happen. And some EMR systems will actually alert you in the EMR if the patient has any abnormal vitals or abnormal labs. It'll trigger a sepsis alert, and then you typically have to do blood work. Lactate is part of that. For adults, for example, normal lactate is 2. If a lactate is above 2, then they're automatically septic. So it typically goes for signs and symptoms. And if they are septic, you have to start the sepsis protocol right away. There's a sepsis core compliance bundle that you guys can look up. Also, the CDC has a lot of information on all this stuff. But the main thing you need to know is early treatment, early detection of sepsis, and start antibiotics right away. But before you start the antibiotics, you're going to have to get blood cultures, a set of labs, and also this person is going to need at least 2 IVs, large bore IVs, and get fluids, and then getting antibiotics within the first hour. So that's sepsis. And obviously, they'll need to be admitted for further IV antibiotics. And then we want to prevent them from getting into septic shock, because if they get into septic shock, they're going to need to go to the ICU. Or if they're in the ED and let's say there's no ICU bed, you'll have to start nor-epi if they're entering septic shock. So it's very complex. One of the things you need to know is mean arterial pressure. Typically, if they're on vasopressors like nor-epi, they'll tell you to keep the MAP, which is the mean arterial pressure, at least 65 to make sure that their body is getting perfused with oxygen. Because one of the issues with sepsis is the body starts going into shock and the perfusion, the circulation is not that great. Then we have diabetes, hypoglycemia or hyperglycemia. You're going to have to know the protocol and the hospital policy. If the patient is awake and hypoglycemic, you're typically going to have to feed them, give them some juice, repeat their glucose pretty quickly, and find out, are they diabetic or are they not diabetic? You got to make sure, did they take too much insulin? Why did it become hypoglycemic? And then hyperglycemia, sometimes they're vomiting, they have nausea, their sugars can be very high, like above 600, and then you have to fix it. Sometimes that goes into DKA, and they might have to go to the ICU. Next, we have anaphylactic shock, an allergic reaction. Worst case scenario for those patients is their airway can become swollen and you don't want them to have to get intubated. So you definitely need to treat that really quickly. Typically, it involves 2 systems, like if they have a rash, shortness of breath, wheezing. So you need to give them antihistamines like Benadryl, and then an EpiPen, typically to stop the reaction before they go into anaphylaxis. And then definitely get the crash cart and an intubation cart just in case. And they mostly also need steroids. So again, it is also a medical emergency because you don't want them to go into that shock state, which is disruptive shock. Then 2 other things that you need to work on is prioritization and delegation. Because in the interviews, they might ask you, hey, there's 4 patients, which one do you see first? And which ones would you delegate? So always it's going to be ABC, airway, breathing, circulation, and that's how you're going to prioritize and then learn how to delegate. So now that you know the framework to answer any clinical style question, most new grads don't realize that there are also behavioral style questions that you need to know. So I'm going to cover that in the next video, and also explain the power of storytelling when you're going through these behavioral style questions. And they're typically questions like, tell me a time where you noticed a change in condition, what did you do? Or describe a difficult patient situation, how did you handle it? And it typically goes into patient experience and those things. So in this video, I'll break down how to answer the most common 5 behavioral style questions. And it'll take you from just being an average candidate to being the one that they want on the team to get hired. So I'll see you in the next video. I hope this was helpful. Again, please sign below for the next webinar so you get your chance to be in the New Nurse to Dream Role webinar, and then check out my coaching program as well.